In this presentation, I'll be describing the capabilities we've developed for phenotyping neurodegenerative disorder risk and severity using sleep EEG biomarkers. Our initiative began in 2018 with funding provided by the National Institute of Aging. To date, we have 12 peer-reviewed papers that summarize our evidence, and we put together an international consortium that are helping with data acquisition, analysis, and publication. So the first question is, why would you screen for neurodegenerative disorders? Well, to answer that question, we started with a questionnaire that was developed by the Mayo Clinic, where they were evaluating the preferences of patients who had recently been diagnosed with REM sleep behavior disorder. We adapted their questionnaire and then provided it to those that were in a retirement living community and who attended a Rotary Club dinner. And what we found was that 87% of those who responded felt it was important to know the risk for a neurodegenerative disorder, even if nothing can currently be done to prevent or cure it. And the reason was they wanted to be able to plan for the future. There are some issues around screening for neurodegenerative disorder that a clinician should consider. First, patients would want to be asked their preference prior to sharing their risk of a neurodegenerative disorder. And also, if you did know their neurodegenerative disorder risk and you didn't share it with them, 91% felt that they would lose trust in their clinician. We also found that 87% would want to learn more about medications and adaptive therapies that could delay onset. So there's going to be some counseling that will need to be done. And also what we found was primarily in the Rotary Club group that they would feel anxious about not knowing when the memory problem might begin, and that could potentially be resolved or at least managed by doing longitudinal monitoring of the sleep biomarkers to see how the risk and severity is changing over time. So given that, let me share with you how we came up with the methods to be able to assign that risk and severity. So we began with a cohort that included patients diagnosed with Lewy body, Alzheimer's, or Parkinson's disease, mild cognitive impairment, isolated REM sleep behavior disorder, and a control group. And we looked across these 6 cohorts and started to identify biomarkers that distinguish some groups from other groups. So here are our synucleopathy biomarkers, those that identify Lewy body, Parkinson's, and REM sleep behavior disorder from Alzheimer's, mild cognitive impairment, and the control group. And as expected with synucleopathies, there is greater autonomic dysfunction. So our autonomic activation index would be expected to distinguish the groups. And we also discovered a biomarker that we call non-REM hypertonia. And it also does a very good job identifying the synucleopathy conditions. Now, for more information about these biomarkers on what they look like and whatnot, that's available in a companion video that we invite you to watch. It goes into much greater in-depth about each of these biomarkers and what the signal looks like in the EEG. So what we're showing here in the histogram is that we're identifying the proportion of each of the cohorts that have abnormal levels for each of these biomarkers. So here what we see is the Lewy body patients, the Parkinson's patients, and the RBD patients. The proportions of those with abnormal autonomic activation index are significantly greater than these other groups. Our next biomarker is the Lewy body disorder biomarkers. We have 3 of those, and what they help distinguish is the most extreme continuum of the synucleopathies. So here we find that spindle duration, REM time, and atypical N3 sleep are all substantially greater in those patients with Lewy body compared to the other cohorts. Our next biomarker is our cognitive impairment biomarker, and that's where we see the increased theta activity during non-REM sleep. And both the relative theta and the theta alpha ratio were all useful in characterizing the Lewy body, the Alzheimer's, and the mild cognitive impairment from those that are showing no current cognitive decline, which are the PD, the RBD, and the control group. Our final two biomarkers are those that showed abnormality in some of the neurodegenerative disorder groups, but not in the control group. So here you can see that sleep efficiency tends to be compromised as neurodegenerative risk occurs. And also, we were the first to report that individuals with neurodegenerative disorders had a greater proportion or likelihood of sleeping more than 2 hours per night on their back. And we think that that might be affecting glymphatic clearance and influencing the speed of neurodegeneration. So we have these 9 biomarkers. Each individual is a little bit different on where they fall for each of the biomarkers. So what we did was we took a subset of individuals in the control group, those with Alzheimer's disorder, Lewy body, and the prodromal synucleopathy, that is the RBD patients, and we used artificial intelligence to derive the probability, if you look across all of the markers plus age, what's the probability of that individual case looking like those who were in the control group or normal, or the Alzheimer's group, the Lewy body, or the prodromal synucleopathy groups. So now that we have a probability or a severity score, we then overlaid that in being able to provide some labeling. So if the winner is more than 70%, they're probably normal or have probable AD or probable Lewy body, or they can have mixed conditions. So here's a case where there's 66% Lewy body. They didn't get to the 70, but that combined with the Alzheimer's gets them the 96%. The next group is what we call likely, and here where the winner is greater than 50%, but less than 70%. So here we have the likely normal, likely AD, likely Lewy body, likely prodromal synucleopathy, or the mixed. Our final grouping is around those that showed that they were normal by at least 45%, but there was some abnormality involved. So here, what we're seeing is they're normal at 45%. There is 47% likelihood of AD, but we really want to skew the risk toward normalcy. So we're calling them likely normal with indications of Alzheimer's, or likely normal with indications of prodromal synucleopathy. So now that we have these risks and severities, what I'm going to share with you is how the classifications and the longitudinal reliability hold up across different groups. So here's our control group. And what you can see is that almost 90% of them were classified as probably normal or likely normal. And for those that what we're calling diagnostic disagreement, the vast majority of those that were left were in the likely, so the less severe NDD risk profile. Next to our Alzheimer's disease group, and what we see here is that 86% were either diagnosed with probable AD or mixed. We see that 14% of them were likely normal with some indications of AD. So at least based on their sleep, they may be less severe. And we had a small percentage of those that came out as probably normal or were identified with Lewy body, which wouldn't make sense necessarily for an AD diagnosis. But here you can see in this case that was considered misclassified, they have encephalopathy. Almost the entire night, they had this very slow wave activity that we classified as M3 sleep, and 10% of it was classified as atypical M3 sleep. So this encephalopathy is a pattern that is common in the Lewy body, and this explains why this individual got classified like they did. Now we're looking at our Lewy body cases, and here 79% had diagnostic agreement. We had some number of cases that we classified as probably normal, and a few that normal or had some AD indications. And the RBD group, now these patients are asymptomatic for any cognitive decline, so it would be expected that a little over 30% of them are classified as normal. These classifications for the prodromal synucleopathy does not include the assessment of REM sleep without atonia. So we didn't have the signature of RBD to use to recharacterize these individuals. Now let's look at the test-retest reliability. If these biomarkers or if these classifications are robust, you would hope that the individual, when retested, would get classified similarly. So here we're looking at 45 individuals that were part of the control group. When they were initially tested, their MMSE score was greater than 28. When they were retested, their MMSE score was greater than or equal to 28, and they had not been diagnosed with mild cognitive impairment prior to the retest. The test-retest window was from 8 to 58 months. And here you can see that over 75% of these cases were similarly classified, with another 22% that trended equivalently. Now, we had one case that increased in severity, and I'd like to share with you that case. This is an individual that was retested 5 years later, and they started out with a risk of prodromal synucleopathy of 24%, and it increased by 42 points 5 years later. And again, because it's a prodromal, there's asymptomatic for any cognitive decline, that would be expected that their MMSE scores would not change. However, this individual would be at greater risk of a future synucleopathy, Lewy body, or Parkinson's. Here's some cases that I call if and when. These were the individuals that were part of our control group. They initially had a normal MMSE score, but prior to retest, they had been diagnosed with mild cognitive impairment. So here's our first case. They were considered normal with indications of AD at their initial test and probable AD upon retest. Well, let's see what happened. They were studied a year later. In 1 year's time, their MMSE scores had dropped from 30 to 25, and the probability of AD increased from 47 to 71. Here's our next case. It took them 4 years until we retested them. Their MMSE scores had dropped by 3 points, and the probability over that 4-year period had increased by 46%. In our third case, this individual had been classified as probably AD initially, and they were classified as probably AD when they were retested and identified with mild cognitive impairment. So here they were. It took them over a 4-year window. Their MMSE had decreased by 3 points, but the probability of Alzheimer's hardly changed at all. Now we're going to look at the test-retest reliability for our Lewy body patients. Here is the reliability we're looking at 6 months, and we see that they get the same classification at 6 months. We had one patient that trended equivalently and one patient with decreased severity. Now, this case that trended equivalent got classified as probably AD, even though they were diagnosed with Lewy body. So let's look at that case. At baseline, they had only a 20% probability of Lewy body. and a MoCA score of 8. 6 months later, the MoCA score fell by 4 points, and the probability of Lewy body increased by a small amount. And here's what happened at 12 months. At 12 months, the MoCA score decreased again, and some of the slowing that is indicative of the Alzheimer's started to get enhanced with some of the synucleinopathy biomarkers, which is why the Lewy body got classified at 87% at the 1-year mark. Here's a second case that showed a decreased severity. Here they're showing a 66% probability of Lewy body at the initial, and then it decreased to 23% at 6 months. And here at 12 months, it increased again to 49%. What we're seeing are some of the risks of looking at these probabilities using a single night. So we recommend a 2 or a 3 night average to make sure that we're getting stable information. This individual showed a steady MoCA score over this period, with these probabilities bouncing around a little bit, that we think is a result of not having sufficient data to use for the risk and severity indices. Here's our Alzheimer's test retest data. We have 9 cases here. Almost 80% of them were assigned the same risk and severity. We had 1 case that showed an increased severity and 1 case with a decreased severity. Here's the case with the decreased severity. They had a MoCA score of 18 and probably AD. The AD went down by almost 20%. The MoCA score increased. And here they are at 1 year, where the AD has continued to decline and the MoCA is relatively stable. So this is a really interesting case, watching it longitudinally, where their sleep quality is getting better over that 1 year period. So now what we're going to do is look at the cross-validation of these severity and risk measures in patients who had no association with the model development group. So that's what we're using for cross-validation. This is a unique group of normal controls. These were not part of our original control group. Here we see 82% of them were classified as probably or likely normal. This is slightly lower than what we had in the control group, because we had 5% of this group that expressed likely synucleinopathy, that's a higher level than in our control group. And again, these are patients who are asymptomatic for any cognitive decline in the synucleinopathy category. This is a group of patients who had recently been diagnosed with sleep apnea. Over 85% of them were classified as normal or likely normal. There were some patients in this group that got classified as with a high likelihood of having a neurodegenerative disorder. And what we found was that the group that what we're calling diagnostic disagreement, in that they weren't showing or hadn't been diagnosed with the neurodegenerative disorder yet, this was associated with age. So we did not see that the diagnosis of sleep apnea in itself increased the risk of a neurodegenerative disorder from a one-time, one-shot snapshot. It could be that if you followed those patients with sleep apnea and they were untreated, they might, as they age, express cognitive decline faster. Here's our mild cognitive impairment patients, where we see that, again, with the range of mild cognitive impairment, it's not surprising that 25% were classified as normal. Those would be the milder cases. And that we also found that over 60% of those that were abnormal were characterized as AD or mixed pathology. When we have 6 cases that we've now evaluated longitudinally, and what you can see is that 4 of the 6 cases got identical classifications when retested. We had 1 case that increased severity and 1 case that decreased severity. In the case that increased severity, what you see is that in 1 year, their MMSE score dropped by 6 points and the risk of AD increased by 19 points. And here's the case that showed a decreased severity. Here they started out with the risk of AD of 86% and they had an MMSE score of 26. It dropped down by 4 points 1 year later. And the risk of AD, at least for those 2 nights that they were studied, the sleep patterns indicative of AD were slightly less. So they went from probable AD to likely AD. Now we're looking at the Parkinson's patients. Again, the Parkinson's patients are asymptomatic for cognitive decline. So again, it's not surprising that some portion of those would be in the normal group. It might be a little bit strange to have a patient with PD getting classified as probable Alzheimer's disease. And now that we're able to look by adding the chin EMG, in this particular case, we found that they had REM sleep without atonia, the biomarker, the signature for REM sleep behavior disorder at a very high risk-wood density. So by being able to add the REM sleep without atonia, we're going to be able to reclassify individuals when this information is acquired. Our final group are the progressive supranuclear palsies. These are pure tauopathies, except the sleep risk and severity characteristics. What we found was they look virtually identical to patients with Lewy body disease. So almost over 85% of them are classified with high severity levels, and a very small portion of them are classified as normal. So in conclusion, we found that the neurodegenerative disorder assignments of risk and severity were relatively consistent across the diagnoses. From a face validity standpoint, they did a good job, and that there was strong longitudinal test retest reliability, and that when there were changes, it could be explained based on other factors. And finally, we believe that the consistency may be influenced by the number of nights studied. So if you want to access all of our publications, you can use this QR code or go to www.advancedbrainmonitoring.com/NDD. Thank you very much.